hosted by the Prugo Biologics. I'm David Kim, and I'll be moderating today's presentation by Drs. Mauricio Araujo and Dr. Jerry Lin. Prugo Biologics is a global leader in biomaterials dedicated to developing products that enhance soft and hard tissue regeneration. Alongside its robust R&D efforts, the company is deeply committed to providing top-tier educational programs for dentists. Today, Drs. Araujo and Lin will share their expertise on grafting around immediately placed dental implants and present cases using Prugo Biologics' innovative biomaterials. Dr. Araujo is a periodontist working both in private practice, Rio de Janeiro, and at the State University of Maringá, Paraná, Brazil. He completed his PhD at the University of Gothenburg, Sweden. He's the chairman of the Perio Implant Research Unit at the State University of Maringá. He and his co-workers published groundbreaking research in the field of ridge alteration following tooth extraction, ridge preservation, bone formation in extraction sockets, and immediate implant placement. He is an ITI fellow, a former ITI chairman in Brazil, and an Osteology Foundation board member. Dr. Jerry Lin is also a renowned periodontist with international recognition. He earned his certificate in periodontology and a Doctor of Medical Science in oral biology from Harvard School of Dental Medicine. His academic roles include lecturer at Harvard School of Dental Medicine, assistant professor at Taipei Medical University, and clinical instructor at National Taiwan University Hospital. He has also served as the past president of the Academy of Dental Implantology, ROC, and the past vice president of the Taipei Dental Association. He's also the founder of the Institute of Advanced Dental Education in 2007 and trained over 1,000 dentists. Without further ado, we will ask Dr. Araujo to start his presentation, which will be followed by Dr. Lin's. At the end of presentation, there will be a time for Q&A. And for the participants that are joining us today, we just wanted to let you know that there could be a little bit of the internet instability because we have Dr. Araujo joining us from Chile, and we have Dr. Lin joining from Taiwan. I am joining from United States, and we have Prugo joining from South Korea. So we have 3 continents from 4 different countries trying to get this program going. So please excuse us if there's a little bit of the lagging of the presentation. It's due to the internet issue. Thank you, Dr. Araujo, and thank you everyone for joining today's exciting presentation.
My presentation is ridge preservation for immediate implant placement. The aim of my presentation is the following: to understand that to be successful in immediate implant placement, it's not enough to place the implant in the perfect 3D position. Because even if your implant is in the perfect 3D position, you have to take into consideration that ridge alterations will take place following tooth extraction. So you have to manage such alterations that take place into the socket. Because even if your implant is in the perfect position, such alterations may lead to discoloration of the soft tissues, to soft tissue recession, to any aesthetic unpleasant outcome. So it's important to manage the socket alterations. And for that, we have 2 options. Either we can preserve the dimension of the ridge of the alveolar process, and that's called ridge preservation, or you can augment the ridge augmentation. In this particular presentation, I will focus on ridge preservation, meaning that from the very beginning, I examined my patient and I decided that the dimension of the alveolar process and the basal bone are good, are adequate for housing an implant. So I'm going to talk to you about ridge preservation for immediate implant placement. In other words, before tooth extraction, I had examined the alveolar process and the basal bone with a CBT CT scan. I had decided the dimension is okay, so I'm going to preserve the dimension. And at the same time, I'm going to place my implant. So it's ridge preservation for immediate implant placement. Well, the most common way to preserve the dimension of the alveolar process is by placing a graft inside the socket. And this graft should be a slow resorbing biomaterial. And why a slow resorbing biomaterial? Because I want it to stay for long periods, supporting the host bone, supporting or providing support for the maintenance of the volume. Now, this socket graft can be done for late implant placement or for immediate implant placement. In this particular presentation today, I'm going to talk about how to preserve the ridge for immediate implant placement. Now, which kind of graft you can use for grafting the socket? There are two grafts that has been widely studied in the literature: bovine with thousands of studies and porcine with dozens of studies. And when you compare bovine and porcine, you see that the outcome are similar. They might have some difference regarding the initial inflammatory reaction. Might be that porcine has a shorter inflammatory reaction than bovine, but the literature shows that they are basically similar. Now, why should you use a graft to preserve the ridge? Why? Why? What is the reason for grafting the socket? Well, you are grafting the socket to provide stability to the woven bone. You see, we know from our studies that we are going to lose the buccal wall. And when you lose the buccal wall, you lose a shield that protects the healing tissues. So the healing tissues are exposed to the soft tissues, and micro movements will take place. And this micro movement will prevent the mineralization of the provisional connective tissue. So there will be no bone formation. If the wound is not stable, there will be no bone formation. It's like my arm. If I break my arm and I don't stabilize the wound, healing will take place, but the healing will not be characterized by bone formation. So the wound is my socket. So when I place my socket, when I graft the socket, I will provide to the wound, especially to the woven bone, stability. Instead of the woven bone become stable for the deposition of parallel fiber bone and lamellar bone, its stability will take place by the connection with your graft. So your graft will provide stability to the wound. And by that, we will increase the amount of bone following the healing. Now, very good. So, but we also you have to take into consideration the following. The sockets are different. Please look at these three different sockets. The one to your left, you have a socket with intact walls, and not only intact, they are thick walls, meaning that these walls will be for a long time during the healing process. They will stay there for such a long time that the day they disappear, the healing tissues are already mature. The healing tissues are already have reached what we call wound independence. Wound independence is when the woven bone is reinforced by parallel fiber bone or lamellar bone. Now, if you move to the center, you see in the center of your screen a socket with intact walls. But take a look that the buccal wall is rather thin. So it's intact, but it's very thin. So will disappear in few days. And when it disappears, that will expose your healing tissues to the soft tissues. And there will be micro movements. And these micro movements will not allow mineralization. Remember that even if you place your graft in these situations, the graft by itself, they are not stable. They become stable when they integrate with the woven bone. So remember, a thin buccal wall may disappear before the wound tissues, the healing tissues become stable. Now, if you move to your right, here from the very beginning, you see that because you don't have the buccal wall, your healing tissues will be in contact with the soft tissues, and there will be micro movements. There will be no bone formation. And you can anticipate that if you do nothing, there will be invagination of the previous alveolar process. For that reason, when you use your graft for preserving the ridge, in the situations like in the middle and to your right, you have to use a membrane. Even if you place your graft, it's not enough to place your graft. You have to place your graft and place a membrane, because the membrane will protect the granules of moving. So the granules can wait for the woven bone formation and get the stabilization of the wound. Now, there is something else. We have also showed in our studies that, okay, the graft provides stability to the wound. It's fundamental for when you lose the buccal bone, you don't lose further volume. Very fine. But it's also very important to show that this volume will remain following the whole healing of the alveolar socket. It has to remain. Now, we have shown that by using xenograft, you remain the volume. In other words, as you can see here on my slides, you can see several BMU, bone multicellular units, that they go to the wound to remove the woven bone. That's the primary spongiosa. The woven bone is the first bone to be formed, but it has to be removed. because the woven bone has not the same loading capacity as the lamellar bone. So the bone multicellular units, they remove the woven bone and they open space for the replacement by lamellar bone. And lamellar bone is bone that really can neutralize and distribute the forces. And it has to happen without removing my graft, because my graft has to become the scaffold, the scaffold, the scaffold that guarantees the maintenance of the volume of the previous alveolar process. So that's the second most important property of the graft. So the xenografts, they have this ability to become there as a scaffold because the osteoclast cannot remove the xenograft. At the same time that he is friendly, he is biocompatible, and he is also conductive. Very good. Now, this is important, but it's not enough. I have to now to touch bases with you regarding the anatomy of the alveolar process when we place an implant. You have to understand that when I do ridge preservation for late implant placement, I graft the entire socket. So I have a huge space to be grafted, right? Not only that, I have a huge recipient bed, and the recipient bed of my wound is the inner walls of my socket. But now, when I graft for implant placement, it's very different because now the space is very limited. It's only the space between the buccal implant surface and the buccal bone. It's a gap between implant and the buccal wall. It's a gap. And not only that, the recipient bed is really small in comparison to the entire socket. Indeed, I even have a avascular recipient bed. That's the implant surface. So the gap is important. And we did that study to show that the anatomy of the gap, the dimension of the gap is fundamental for you to achieve a good ridge preservation. Now, in this particular study done with the group of Dr. Bob Levine from Philadelphia, we had the aim to identify what is the gap dimension, ideal gap dimension to have the best outcome of my ridge preservation procedure. We identified 42 patients who received 5-1 implants at the maxillary center incisors. For implant placement, we identified two groups, or we divide the patients into two groups. A group in which the gap was 2 millimeters or narrower, and another group in which the gap was larger, was wider than 2 millimeters. Here you can see the surgical procedure, the intervention. Yeah, to your left, before tooth extraction, implant placement. Here we have a gap that's much wider than 2 millimeters. The graft was placed in the gap, suture. Here you can see the final crown, and here you can see the CBCT scan following 5 years. So we re-examine the patients after an average time interval of 5 years. Now, I would like to summarize the outcome of that study with this table. This is a linear regression model with the thickness of the buccal wall as my dependent variable. So I want to tell you how to achieve predictably a thick buccal wall covering the buccal aspect of my implant. Now, what's important to achieve a buccal wall that's 2 millimeters thick? Now, let's go. Is place a connected tissue graft important? No. A connected tissue graft has nothing to do with bone formation or bone preservation. To have adjacent implant, is this important? No, it is not. To have an implant diameter, narrow implant diameter, I myself, I only use narrow diameter from premolar to premolar. Of course, a narrow diameter increases a lot the likelihood that you are going to have a wide gap. However, if you have a standard diameter implant, you place in such a way that you have a gap that's larger than 2 millimeters, the outcome will be the same. Finally, you have a gap larger than 2 millimeters. Yes, this is the only, this is the only factor that significantly influence the thickness of your future buccal wall. Thus, grafting a gap that's larger, that's wider than 2 millimeters following immediate implant placement is pivotal for achieving a buccal wall that's thick and high. Now, in this following study, I'd like to address the following. How can I predict not only to have a thick buccal wall, but to preserve the entire alveolar process? What is the anatomical predictors to associate with immediate implant placement that are related to the minimum amount of ridge loss? For that reason, we took 25 patients in which, in one central incisor, it was performed tooth extraction, immediate implant placement, and ridge preservation by means of socket graft with xenograft. And we are going to compare the amount of preservation of the alveolar process with the contralateral central incisor, the contralateral pristine central incisor. And by that, I'm going to see what are the factors that control, that are associated with the alveolar process preservation. Now, here are my primary and secondary variables, and I'd like to show you this linear regression model that summarizes the outcome of my study. So this is a linear regression model with the reduction of the alveolar process as the dependent variable. Now, what are the variables that are really important to preserve the ridge when we do immediate implant placement? Number one, the gap. The larger the gap, the wider the gap, more you can perform your graft. The thickness of the buccal wall. The thicker the buccal wall, the better, because it means that the buccal wall will remain for longer period. And if your buccal wall is too thin or is not existent, you have to use a membrane to compensate for the lack of the buccal wall. The width of the alveolar process, this is obvious. The larger the alveolar process is, the larger, the wider, the larger will be the gap. And finally, the tooth angulation in relation to the basal bone. So if the basal bone, a line representing the long axis of the basal bone, this line makes an angle with a line represents the long axis of the root. If this angle is larger than 15 degrees, it means that your alveolar socket is outside the bone envelope. And we have performed several studies that shows that when you have the alveolar socket outside the bone envelope, you have much more bone loss. So this is fundamental. These are key anatomical guidelines that you have to follow to achieve the best outcome out of your ridge preservation for immediate implant placement. Now, let's show you some cases that illustrates everything I told you. So I have this patient that have lost the right central upper central incisor. Here, let's examine the patient. That's the treatment plan. Chief complaint, crown loss, diagnosis, root fracture. Let's examine the anatomy. Let me tell you once more. You have to have a CBCT scan before tooth extraction, at least at the static zones, and for sure before planning for immediate implant placement. If you don't have a CBCT scan, you cannot properly examine the case. Now let's go. Anatomy. This patient has adequate thickness and height. Fine. So I can preserve, because if there was no adequate thickness of height, should be for ridge augmentation. Primary stability is present because you can see a very large basal bone. It has a very thin buccal wall. Thin buccal wall means something less than 1 millimeter. So I need a membrane. Now I have an alveolar process that's wider than 8 millimeters. So I have plenty of space for housing my implant. The tooth is inside the bone envelope. The tooth angulation is less than 15 degrees. So it's inside the bone envelope. And it has short crowns. So what is my therapy? First, crown lengthening. And I can either go for late implant placement or for immediate implant placement. I'm going for immediate implant placement. So here you can see I have performed the crown lengthening. I have placed my, always do immediate implant, connective tissue graft for immediate implant placement. I place my graft and my membrane, and here's the final outcome in which I was able to preserve most of the previous volume of the alveolar process. And here you can see the final outcome with the smile of the patient. Now I can move to another case. Again, the patient has a problem in the central incisor, the right upper central incisor. Let's examine this patient. Chief complaint, crown mobility because of the fracture. Diagnosis, root fracture. Anatomy, adequate thickness and height. Primary stability is possible. You can see here on my planning, my digital planning, that my implant is inside the basal bone at least 5 millimeters or more. There is a very thin buccal wall, so I need a membrane. Alveolar process width is much more than 8 millimeters. It's inside the bone envelope, and the tooth angulation is less than 50 degrees. So it's a perfect case for immediate implant placement. Now I can go, of course, if you like to do late implant placement, that's fine with me, but I'm going for immediate implant placement. Here you can see the extraction, minimally invasive tooth extraction, implant placement, always with a surgical guide. The implant place 3D position. Now I do it tunneling. Here you can see I'm placing the flex membrane, the membrane, the collagen membrane from Pugu. It really keeps the convexity of the previous shape of the alveolar process. Now I'm placing my Pugu collagen. I cut this into slices with my scissor. I place in the gap, and here I place my crown back. And here you can see in 50 days of healing, it looks beautiful. 15 days is the wound is really very little inflammation. And now you can see the final resolution, and with a good maintenance of the alveolar ridge. And here you can see the final outcome patient with her new smile. So in overall conclusion, ridge preservation followed by immediate implant placement can successfully preserve the dimension of the alveolar ridge, and the anatomy of the socket and the gap is fundamental. and also using the proper xenograft graft is fundamental for the success of immediate implant. Thus, I thank you very much for your attention. This is my Instagram addresses that you can get in contact with me. I thank you very much for your attention. Back to you, Dr. Kim.
Well, I think it's great because what I'm gonna do for today's presentation, my presentation today. Hold on, let me check on the video. Okay, all right. Thank you for the Raul's presentation because what I'm gonna do today is on immediate implant placement as well, and so it would be a very good combination because Araujo already went over the fundamental and basic science of the immediate implant placement and bone biology, bone augmentation. So my topic today is to kind of differentiate the socket augmentation versus immediate implant placement, but then I would focus more on the immediate implant placement side because that's a decision making that we should do. What we should do and what we should avoid of doing it. So let's look at the. All right. Well, I'm Geraldine as Dr. Kim's introduction. I'm based in Taiwan. Even though I'm a part-time faculty at Harvard School of Dental Medicine, I'm located in Taiwan. I have my own private practice, and I have my own dental training center ever since 2007. And about 10 years ago, I started also running a dental laboratory. So for me, I am a clinician, and even though I teach at school and also do some study and publish articles, and what I would like to do is more clinical oriented. So for today presentation, I would kind of ask ourselves, when do we do immediate implant placement? So when we take out a tooth or take out teeth, and that's a moment that you should consider. Well, should we do some preservation, or can we place implant at the same time, or we can just do everything together? And on top for the aesthetic zone, we can also add some piece of connect tissue to bucket up the soft tissue, to augment soft tissue, and to make it better. So that's a decision making process. So my concept actually for in terms of socket augmentation versus immediate implant placement, whenever primary stability can be obtained and whenever it won't compromise any aesthetics or the position of implants, then that's when we should consider immediate implant placement. And of course, the adequate available bone housing is the key, always the key. That would support us to grab the site well. So now we are not talking about just, for example, um, in a we can be more efficient to do some treatment planning. Uh, any case, whenever we extract the tooth, we should first consider immediate implant placement. Later on, we should go. Well, if it is not possible, then we can do the socket augmentation, or we just wait for stage, or even for late implant placement. So that's my concept. Always consider immediate implant placement as the first option. Now that's question. Another question. When not to do immediate implant placement, but rigid preservation. So that would answer this question. And whenever we kind of bump into those scenarios, first, a very large pathology, sinus proximity, nerve proximity, and traumatic or large, huge vertical or horizontal bone loss, and very difficult to grab it at the same time. And or sometimes we have a situation that implant was very difficult to be positioned or to aim it right. And of course, aesthetic could be another issue that we should consider. So, other than those issues, then the immediate implant placement is possible and feasible for us to make the right decision and then the right clinical um, treatment. So I just take sinus proximity as the example, or which we will not do immediate, even though it can be done. I have another case for immediate implant placement. I take that this as an example too. You know, sometimes we can have a better situation than we can do immediate. Even though sinus proximity is kind of it's not a contraindication, but it's sometimes very crucial. We should be very cautious doing immediate at the same time. I'll take this case for example. A fracture upper second molar, second premolar. Is a fracture molar, so there's a fissura and abscess present beforehand, and now there was an abscess still on the soft tissue. If you can look into it, well, so from the panoramic radiograph, the root tip is located close to the sinus. We call it a sinus proximity. Of course, we can do extraction, sinus elevation at the same time, but then it will be um, certain risk because if we perf the sinus and we have the extraction site, if we cannot close the wound very well, then we might bump into the oral internal communication. So for those kind of case scenario, that's something we should avoid and try not to do because uh, based on Murphy's law, whatever is gonna happen would could happen. So that's why for me, sinus proximity is one of the contraindications for immediate placement. But there, of course, there's some exception as well. So for this particular case, I extracted tooth. There was not only the sinus proximity because of fracture, there was a penetration, and if there were not the sinus proximity issue, this would be a perfect site for immediate implant placement. But because the sinus proximity, then I just grabbed it and cleaned out the site very well. Grabbed the bone membrane, close it up, and it could this is the sort of socket preservation, socket augmentation procedure done, and we just wait. It's not uh, a primary closure type. I kind of live the sort of uh, secondary intention healing with membrane exposure, but it's a very minor, very small area of the exposure. So in 10 days, the healing was just right, just well, and then epithelium migrated over the wound. In 7 months, you can tell that the bone healed up very well. So we have very good bone, very wider bone, allow us to place a very good implant in position, and of course, angulation wise. And it was in bone, and can the implant the site can be restored very well, and this is post up. So that's the one of the example of why shouldn't we not to do immediate, but circuit augmentation or preservation sort of technique. And then when I rephrase it, whenever primary stability can be obtained, and then there was nothing that would compromise any aesthetics or position of implants, and or the bone housing issue, then we should consider immediate implant placement. And where? Um, when mine was resin, we didn't consider really well that molar could be a perfect site for immediate implant, but turned out to be molars or good site for immediate implants as well. So my opinion is that everywhere. So no site limits. It's from molar to incisors. Of course, from the aesthetic zone, it's more of the aesthetic driven, and for the posterior teeth, then we should consider it will be more toward functional. Then we should um, place like strong larger implant and for the posterior side, right? Let's begin with a mandibular molar. Mandibular molar, well, I think nowadays we should consider mandibular molar as a easy site to learn immediate implant placement. I just take this for example. And the technique I use, there are so many different techniques we can use to for the immediate implant placement. For this case sample, I use a heating abutment technique. This is a technique I invented a few years ago, well, more than 10 years ago. Then I use a heating abutment and bone membrane to seal up the wound. It's not something new, but if you talk about 20 years ago, that's something that is well, we're still learning. But now it's a quite mature technique. So patient presented fracture molar and with suffocation involved through and through. And this is clinical view. The tissue has been well. She had been on antibiotics, so the tissue tone looks fine. When I this is when I consider extract the molar. So because even though it's infected, but the molar is lower molar, two roots still very strong. So in order to preserve all the bone and then extract as traumatic as possible, section split the roots and then extract it as a single root approach. And then I did my osteotomy through the septum, interradicular septum. And this is how I do it. Like I drill it through the septum and then put the guide pin to make sure that I'm in a good position. And of course, I try to engage the bone to stabilize my implant because the septum is uh, not the only place, but for this particular case, that's the very good spot for immediate implant. So I did my osteotomy toward the septum and cleaned out the site very well and grabbed it, of course, at the same time and with the bone and membrane. So the membrane wise, I use resolvable membrane because this is the extraction fresh extraction site. So and then the site the healing wise more I would say higher healing potential. So I use a bone resome membrane the combination to build up the bone. And of course, it's around the implant. So we can also call it peri-implant GBR or the immediate implant placement with the simultaneous GBR procedure, and we sealed up the wound very well with the membrane, and of course a little bit add from the soft tissue of on the site, and we should kind of suture it. And this is the after grafting. So this is the result. All right. So this is mandibular molar. What about maxilla molars? Like a lot of time, is so frequently we can see the sinus proximity around the upper molars. I just want to take this molar as example. Like on the contrary to the premolar, second premolar, I presented the sinus proximity, then I should consider the stage approach. But this particular case is a molar, uh, upper molar, first molar, and it's a fracture. Not much of the information infection, but it's hopeless. So when I section the upper molar, just the way I section it on the mandibular molar, I found there's a very intact interradicular septum for this particular case. And there were a good bone. This is definitely good bone around here. Even though the sinus proximity means that the apex are close to the sinus, but then we have a very good septum to work with. So what I did my osteotomy. I did my there's a little bit of a sinus elevation by Crasso approach, and then grafted bone and membrane as a heating abutment technique, as I mentioned. Um, so even though if you look at this molar, it's I just did my osteotomy into the interradicular septum. I was able to achieve 75 ISQ, which is very well, very good stability, right? I mean, in 4 months, I mean, the extraction, 4 months, I would achieve the 75 ISQ. Um, so the initial stability is good for immediate implant placement, even though I did a sinus elevation at the same time. And as I mentioned, whenever sinus proximity, it's a high risk. But remember, some exception can happen for this particular case because there was a certain time issue. So that's why I decided to do. And then I evaluate the original bone from the interradicular septum. It I have enough bone to engage, have my implant engaged, and then I was able to lift up the sinus. So that's why I decided to do my immediate implant placement into the septum, and then lift up the sinus at the same time. Well, of course, this is double of the risk, but then it went very well. It's not common that I would do it, but then it's possible to do it. So this is the definitive restoration done, and if you look at the bone, very well, like heating wise, stable. So those are molars that are from the mandibular molar and upper molar. Now let's move up to the premolar. Can we do the immediate implant on premolars? Yes, of course, because premolar is single root or two root premolar. And the example I would like to show you is the custom heating abutment technique. This technique, well, there was a publication in 2015, but I started doing this really early. I think my first case I did it, that was at 2000, around 2010. So I started up, 2008, 2008. That's when I start of the technique. I don't know if I invented, but when I did it, that's the time I haven't ever seen any people did this type of approach. So what I did for this particular case is a second premolar. There was a fracture, root fracture. So apparently it was in between uh, two implants, but patient didn't want to have the implant supported bridge. Otherwise, I could have just removed the one implant crown and one implant crown back, and then change the as a to a implant supported 3 unit bridge. But she didn't want it. First of all, she has to remove the two existing crowns, which is were function nicely. So we decide to do the immediate implant placement for this premolar. So I extracted, grafted. I did use a temporary abutment to make the custom healing abutment and sealed up the wound, sealed up the extraction site. And this is post-op, and this is the final restoration, definitive one. So it healed up very well. See the bone remains stable. So that's a different technique. Well, there are a lot of techniques that wish I could go over every single technique that for you, but because limited time, I just pick a few that very kind of example for immediate implant protocol. What about aesthetism? Aesthetism can be done like Dr. Araujo showed the case in aesthetism case as well. So this is case I did a stage loading. I use a healing abutment, but then I add connective tissue to bulk up the soft tissue for aesthetics reason. Patient had a fracture upper right central. I extract the tooth, and if it in a pre-op radiograph, you can appreciate the well, there's a good bone. So I think this I can place the implant very well, and that Rujo mentioned about the jumping gap issue. For me, I prefer to have a jumping gap more than two because it has been very stable, and I grabbed it. And of course, I grabbed it, over grabbed it because the those grafts I put on that could turn into soft tissue. And not only the graft turned into soft tissue well, I also took a piece of connective tissue from the palate and grabbed it onto the extraction site to seal up the extraction socket at the same time to bulk up the soft tissue. So in this manner, I would have very good soft tissue around the implant because our natural teeth always have insufficient, not always, I mean, majority of the time we have very thin, uh, based on the study, we have thin tissue on the buccal, but it's adequate for natural teeth, but sometimes not enough for the implant. So would it would be better to augment the implant side with a connective tissue for that reason. So this is the definitive restoration. We try to match up the contralateral side, and it went very well, and very good bone on the buccal to preserve it. This is before and after. So that's stage for immediate implant placement, but stage. What about immediate loading? So if the condition perfect, we'll do the immediate loading whenever. Well, there are a lot of criteria for immediate loading, like you can take ISQ and immediate loading. In general, people think a lot of people think 65 would be good fit for immediate loading, but I don't like 65 because I ever had a case reach to 70 ISQ and still got failed. So ever since then, I use 75. So I personally like to have the criteria of ISQ 75, insertion toward more than 45. People use more than 30, but then I like to use the more than 45. So for the particular case that's referred to me because he fell on the bathroom and injured the front teeth, and there was fracture line for the upper central. So patient referred to me, I extract the central and I place the implant, and it's very stable. So I just put temporary abutment, and I use graft it, and I use the flowable composite to fill up the space, the wax up space, and of course I adjusted a little bit, and I also stain the crown the provisional to make it perfect better. Uh, this after the provisional in 4 months, and I changed the second set of the provisional crown, and then of course, we already found that the lateral incisor got fractured as well. So I decided to remove it um, and use the central as a cantilever solution for the lateral. So it's uh, cantilever option, and it's the final restoration done. And so, all right. So for today's presentation, I would have some take-home message for all of you. First, socket management is essential and crucial for both immediate and stage approach. We have to know the socket very well, and then we have to manipulate the socket very well in order to place immediate implant. So to place, in order to place immediate implant very well, we have to know the socket um, better. Why? Because it's the immediate implant placement just like a socket augmentation, but we have the implant inside. So that's the reason why we need to kind of acquainted with socket management. And ridge preservation is capable of preserving bone and preserve the bone for implant site development. And that's a pretty common, and we have a webinar for this last time. And for today's presentation, because immediate implant placement, I think it's predictable if we could manage well with the bone, manage well with the soft tissue, manage with risk assessment, then immediate implant placement can be done very well, and that with a very high satisfaction from the patients. So in order to place implant well and adequate, GBR is crucial. No matter what, we have to consider GBR as the option, not the option, as a must for immediate implant placement, because after the extraction, there is certain bone may undergo remodeling, resorption. For GBR, that can prevent that from happen. So GBR is crucial for both immediate and stage approach, especially for immediate implant placement. Make sure that immediate placement alone cannot prevent bone from resorption. That's a study by Araujo 2005. So I would like to thank you all for your attention. And I know it's a very short presentation, so it's very condensed. And you are more than welcome to reach out to me through the social media, email, or anytime that you can at me. So, and also I posted the videos on YouTube. It's free for everyone. So you can go on to the YouTube, and I will keep posting, uploading videos for your reference. Those are clinical videos. I will keep uploading it. And thank you.
Thank you, Dr. Lin, and also Dr. Araujo for your wonderful presentation. I know it's very late in Asia, so we have a time for 2 questions. There are so many questions, but we'll try to answer all of them. We don't have a time to answer all of them, but one important thing is there any difference between using resorbable and non-resorbable membrane when doing a ridge preservation with an open membrane technique? So we know that Prugo has both non-resorbable and resorbable membrane. So maybe with Dr. Araujo, Professor Araujo, if you could give us your comment on using resorbable versus a non-resorbable membrane for open membrane technique. Sorry, you are muted. So if you could.
In terms of outcome, it's the same.
Okay.
However, clinically, we take into consideration that when you leave exposed the collagen membrane, that is not a problem. And by the way, the membrane is needed at the buccal aspect. At the socket entrance, you only need that for 15 days. After that, you don't have to have a membrane at the socket entrance. The membrane is for the buccal aspect. So, in this sense, taking that into consideration, if you say that use your non-resorbable membrane because you want to have something that is not degradable by the enzymes of the oral environment who can reach the socket entrance, I don't think that is does not justify. So, in my opinion, for this particular situation, I would go for collagen membrane. Again, I know it works in terms of final outcome will be the same, but I think it's more complicated to use a non-resorbable biomaterial when you just want to preserve the reach.
Thank you. And Dr. Lin, I think I'd like to ask you a question that some patients nowadays prefer use of the alloplast over xenograft or allograft, potential fear of infection. What is your insight on this topic?
You mean alloplast or
Yes, like to use a synthetic rather than using a xenograph or the allograft.
Well, I personally don't like synthetic much because first of all, based on this study and all the histology and for past 20, 30 years, we know that well, synthetic is possible to be used for socket grafting or any bone augmentation as well. But the problem is that it's not the it won't give synergetic effect. It's a more like a filler, but then it won't give much of the space making. And then first of all, it depends on because synthetic there are a lot of material out there. For example, beta TCP has been widely used. That the problem of it is that it resolve a little bit faster. So you sometimes lose it will lose the capacity of maintain the volume. So that's why it's not the ideal solution. It could be done, just like a lot of things could be done. But then for me, my choice will be xenograph, allograft, because they have been we have been using for 20, 30 years and been predictable. So for me, I would that will be the material I would choose. Thank you.
Great. And Professor Araujo, someone, one of the participants asked, can bone regeneration capacity be improved by the regular use of the vitamin D?
Well, okay, if your patient has a shortage of vitamin D, I think that will play some role. But if your patient is a normal individual, he is going to heal. Anyhow, healing will take place. It's more important for the healing outcome of well, there are two situations preserving or augmenting your surgical technique, the anatomy of the site, and all these local things, unless your patient has a shortage, because you can give as much vitamin D you want, but if you don't perform a good surgery, the anatomy doesn't lead to stability of the wound. There is not blood flow to the wound site or not availability of cells. I don't see how that's going to change the game.
Sure. Okay, the last question for today for Dr. Lin was, in a busy private practice, how do you make a decision whether to do an immediate implant placement or do a delayed implant placement? What is your criteria in terms of the selecting the immediate versus the delayed?
Right. Okay. Well, for me, I always put immediate as my first option, priority. So on this, there's something that would compromise the decision. Then I would go delay. For example, if it was a huge defect and especially vertical bone defect, and it's larger than something we can do as an immediate approach, then I would go delayed. And delayed type of treatment, for example, that early bone augmentation or late bone augmentation, we can manage the soft tissue very well and also close it up well as primary closure, given a good environment for bone augmentation. Other than that, I mean, immediate implant placement always my top priority. So I list a few that this contraindication. It's not really contraindication, but something we should be careful about. And of course, I can. That's why I put two sinus as an example. One for stage, the other one for immediate implant, because we can always choose something that could be risky, but then if we manage well, we can conquer it as well. So I think this is my answer. Always have the immediate as a top priority.
Great. Thank you so much. So thank you everyone for joining us on this beautiful day for our Region webinar series. We do have an exciting program coming up for year 2025 as well. So please be in touch and you'll receive an email from the company regarding the feedback from today's presentation. And also I'd like to thank Professor Araujo and then Dr. Jay Lin for participating in this great webinar series. And we hope to see you in year 2025 as well.
Thank you, Dr. Kim. Thank you,
Thank
Dr.
you.
Marujo. Thank you,
Yes.
everyone.
Jared.
And thank you so much for the Approval Biologic for providing this platform, the Regen webinar, for the clinician to really share their interests and ideas and expertise. So we hope that this will be a great platform for everyone from all over the world to participate and then grow together in knowledge. Thank you.
Thank you.
Okay.
Bye.
Bye.
Be insightful. Pergo Biologics.